Welcome to Psychopharmacology. Okay, so what exactly are we doing when we practice psychopharmacology? Now, I don't want you to think about what we say we're doing, or not what patients hope we're doing, or not even what the textbook implies you're doing. What are we actually doing? Psychopharmacology is not the art of curing mental illness. It's the practice of mitigating symptoms in the context of uncertainty. That distinction matters more than you realize, especially as you're about to try to help patients amidst that chaos of daily life. Now, most of psychiatry, uh, in the cases as in cases in life, are trade-offs. Right? Most of life and psychiatry is going to be trade-offs. We don't have a lot of fixes. We don't have cures. We are simply willing in psychopharmacology to trade symptom reduction for side effects. And we trade certainty for probability. And we trade clean theories for that messy thing we call human life. So if you miss that early, and if you think this course is about mastering the answers instead of learning how to think, you're going to either become very, overconfident or greatly demoralized, and sometimes both. So let me say this clearly at the start of this course. There is no pill for being human. There are medications that can reduce suffering. Some can increase your capacity for suffering. And there are some medications that can stabilize or contain or soften symptoms enough for a person to engage in therapy or have a relationship that's functional or go to work or learn to find meaning in life. But there's no medication that's going to cure grief or erase past traumas or resolve your existential despair as you try to find a purpose in this life. There's no pill that's going to substitute for life. And that's not a failure of psychiatry or pharmacology, that's just reality. Now, why do I start here? Well, the reason I start here is because many clinical errors in psychopharmacology come from false certainty. They come from well-intentioned people confusing correlation with causation. Mistakes come from mistaking symptom improvement for disease resolution. It comes from believing that because something helped, therefore it must explain what has happened. And that kind of thinking is not only seductive but dangerous. So the first half of this course is intentionally focused on research, theory, and limitations before we ever walk through the disorders. Because once you start seeing patients, symptoms are going to pull on you emotionally, and pressures are going to come from patients and families and supervisors and teachers and coaches and the system in which the patient is living in. And without a solid conceptual foundation, it's going to become very easy to prescribe reflexively rather than thoughtfully. So here's the mindset I want you to adopt before we begin. So you are not here to become prescribers. You're going to become skilled clinicians who can sit inside that uncertainty without panicking. Your job is not going to be to eliminate all symptoms. Your job is going to be to help patients build resilience and capacity. And it will often be very incrementally, and it's going to be imperfect, and it's going to take time. Because if you recall from the last course, these symptoms did not happen overnight. It took time to get here. It's going to take time to unwind this. And that work is hard, and that work requires humility, and it's going to require you to be intellectually disciplined. So throughout this course, I'm going to pose several questions to help you learn how to think through psychopharmacology. And I want to share with you how experienced clinicians should think. And sometimes it's going to sound confident, and other times I'm going to be very hesitant and provisional. And sometimes I'm going to leave you with questions unresolved on purpose to stimulate your own thinking. So as we move forward, keep in mind that psychopharmacology does not replace psychotherapy, and it doesn't replace finding meaning, and it doesn't replace social context. All we're doing with psychopharmacology is creating space, buying time, and creating some level of stability so that the work can unfold. And what the patient does with that space, that's where the healing happens. So with that frame in place, we're going to talk about why theory matters and why getting it wrong is going to quietly shape every clinical decision you make. All right, so the first objective I want to get to is to help you build this theoretical foundation. And this is not going to be about memorizing models. This is going to be about understanding what kind of claims psychopharmacology can make and what kind it cannot make. And the theory is going to give you the guardrails. So without it, every new study is going to feel very convincing. Every anecdote is going to feel decisive. Every symptom is going to feel like it demands an immediate medication response. A theoretical foundation is designed to slow you down enough to help you ask the question or to remind you to say, what am I actually targeting here? The second objective is to navigate complex diagnoses. Now, most patients you will see do not read the DSM. They present with overlapping symptoms and partial syndromes and medical comorbidities and trauma histories and substance use and social stressors. So when I say navigate, I mean learning how to move through the ambiguity without forcing this premature interpretation and label. Because remember, those labels are very sticky in psychiatry, and we're going to be here so that you learn how to reason through patterns. The reasoning matters more than the diagnostic certainty, which you will notice will often remain elusive. The third objective here is to lay the groundwork for evidence-based prescribing. Now, this is groundwork. This course is not trying to turn you into a reflexive prescriber. It's going to try to teach you how to interpret evidence, how to read studies critically and understand their limitations, and to recognize when evidence applies poorly to the person in front of you. Evidence-based does not mean evidence-obedient. It means evidence-informed, combined with clinical judgment and ethical restraint. The fourth thing we'll talk about in this lecture today is how do we enhance your clinical confidence early. But this should not be misunderstood. Confidence does not come from certainty. Confidence is a skill that's built when you practice knowing how to think when you're unsure. So I want you to leave this course, this lecture, able to say, I don't know yet, but I know how to figure out what matters next. So that's the kind of confidence that is steady. It doesn't collapse under pressure from patients and external incentives and supervisors and the system that the patient lives in. And also, I want to stoke for you this insatiable lust for knowledge. Psychiatry can be very intellectually dangerous territory. The brain is complex and all the data is messy and the stakes are human lives. So if you ever feel like you're done learning in this field, that's a warning sign. That's not a milestone. So I want you to be curious and slightly unsettled. And when you read studies, you need to ask yourself, wait, does this really prove what the claim says? The clinicians who do the least harm are not the ones with the most answers. The ones that do the least harm are the ones who remain teachable. And this course is not about giving you certainty. It's about giving you disciplined humility. You need to develop the intellectual tools and the capacity to think clearly when the answers are not so obvious. So with that frame, we're ready to talk about the main concept of harm and why first do no harm is often much harder in psychiatry than it sounds. So this slide is deceptively simple. It's a question that you will ask over and over again. Simply, is this good? Now, when you see a medication study, especially early on in your career, it's very tempting to answer this question too quickly. You'll see a study, you'll say, okay, it's published, it's in a peer-reviewed journal, the p-value is significant, the abstract sounds confident, and so your brain's going to say, yes, this works. But in clinical psychiatry, the more important question is rarely, does it work? The more important question is, for whom? How often? And at what cost? And that's where we get into this concept of the number needed to treat, the NNT. So plainly, the number needed to treat is the number of patients who must receive a treatment for one additional patient to benefit compared to placebo. So if a medication has a number needed to treat of, say, 5, that means 5 people take the drug. One person benefits because of the drug. The other 4 people would either have improved anyway or receive no meaningful benefit. So is this drug good? So this is where correlation quietly masquerades as causation, because when you see a symptom improve in practice, your brain wants to attribute it to what you just prescribed for the patient. But statistically, many of those improvements were going to happen regardless. So that doesn't make the medication useless, but it does demand a little humility on our part. So in psychiatry, many commonly used medications have a number needed to treat of between 5 and 10. Some are higher. That means most patients do not experience the specific benefit demonstrated in the trial, even though the trial is positive. So when we ask, is this good? The honest answer is often, it depends. It depends on what? Well, it depends on the severity of the symptoms, the risk of side effects, the patient's values and tolerance for uncertainty, the availability of non-pharmacologic options, and what benefit actually means in that person's life. So here's where we get into trouble. If you don't understand number needed to treat, you may be inclined to overestimate how powerfully effective medications are. And you may attribute normal symptom fluctuation to pharmacological causation. And you may be tempted to escalate or stack medications unnecessarily. And you will likely feel confused or frustrated when the outcomes don't match the expectation. So this is one of the reasons psychiatry can feel demoralizing early on, because expectations could have been set incorrectly. Psychopharmacology is rarely about a dramatic transformation. It's about modest effects applied thoughtfully over time. And that's not a failure of the field, it's the reality of working with complex systems. You know, you're working with the brain and the environment and their relationships and trauma and meaning. So when you read a study, you need to train yourself to pause and ask, what's the number needed to treat? And what does benefit actually look like? And what am I assuming is causal that might just be correlational? Because that's how you're going to be smart. And not fool yourself. You're not going to be careless by being overly impressed by clinical findings. You're going to have to learn to say, this helps some people sometimes, and that might be enough. And then hopefully you will practice safer and more ethical psychiatry. And as we move forward, we'll keep returning to this idea, because medications don't need to be miracles to be meaningful, but they also shouldn't be treated as proof that you actually understand the problem. All right, well, we've talked about benefit. Now we have to talk about harm. Remember, first do no harm. That sounds simple enough, but in psychiatry, it's anything but. Because harm in psychiatry is often not dramatic. It's not a rash or a lab abnormality or even an ER visit. It's subtle, and it's cumulative, and it's easy to miss, especially early on. So this is where this other concept of the number needed to harm, the NNH, becomes just as important as the number needed to treat. So let's define this plainly. The number needed to harm is the number of patients who must receive a treatment for one additional patient to experience an adverse effect attributable to that treatment. So, if a medication has a number needed to harm of 10, that means 10 people take the drug, one person experiences a meaningful harm because of it, 9 do not. So here's the uncomfortable part. That harm may not show up immediately. It may not even be recognized as medication related. In psychiatry, harm can often look like emotional blunting, cognitive slowing, weight gain, metabolic drift, sexual dysfunction, sleep disruption, agitation that gets misread as worsening illness, or like subtle losses of a patient's sense of self. And because these changes often occur gradually, both the patient and the clinician may adapt to them without ever naming them as a harm. So this is where good intentions can still lead to poor outcomes. So if you only focus on that number needed to treat, if you're only asking, is this helping, you may miss the more important question, at what cost? So ethical prescribing lives in the space between the number needed to treat and the number needed to harm. A medication with a modest chance of benefit but a low threshold for harm demands caution. A medication with meaningful potential for benefit but serious downside, that demands some shared decision making on your part. And here's the part I want you to hear clearly. Avoiding harm does not mean avoiding treatment. It means being very honest about the trade-offs with your patient. Some patients will choose symptom relief even with side effects, but others will not. Your role is not to decide for them. Your role is to name that risk clearly, monitor for it actively, and be willing to stop or change course when it's no longer tolerable for them. So this is why psychopharmacology is not just a technical skill alone, it brings a little bit of moral skill. Because every prescription carries that probability of benefit, but also the very real probability of harm, and an ethical responsibility to revisit both of those over time. So if you ever catch yourself thinking, at least it's not hurting them, well, that's your cue to slow down, because in psychiatry the harm is often quiet, and quiet harm is the easiest to rationalize. So as we move forward in this course, I want you to hold those two numbers in your mind always. How often does this help? How often does this harm? And just as importantly, how will I know if harm is happening in this patient? Now, next we're going to talk about theory and why so much of what we do rests on models that are useful, often incomplete, sometimes misleading. That's not a weakness of psychiatry, that's just the starting point for how do we know how to do this well given our limitations. So when I say it's all theoretical, I don't mean that psychiatry is fake or careless or unscientific. I mean something more precise and uncomfortable. I mean that every psychiatric diagnosis is a model. Not a lesion you can point to, not a lab value you can trend, not a pathology slide you can hold up to the light. It's a model. So let me ask you this question directly. What is mental illness? What do we mean when we say a person has a psychiatric disorder? Is it a chemical imbalance? Is this a circuit dysfunction? Is this maladaptive learning? Is this trauma that's encoded in the nervous system? Is it a social context overwhelming coping capacity? The honest answer is sometimes parts or all of those things, but never usually just one of those items alone. See, psychiatry sits at the intersection of this biology, psychology, and environment. And unlike other areas of medicine, we rarely get a single cause story. So instead we have to infer, we observe patterns, we cluster symptoms, we test interventions. And if something often helps some people, we build a theory around it. That's how complex sciences work. But it doesn't mean when you prescribe a medication, you're not correcting a known defect. You are intervening in a system based on probabilistic reasoning. And that matters, because if you forget that diagnoses in psychiatry are constructs, useful shared constructs, you may begin to treat them as concrete diseases with definitive fixes, and that's where clinicians get into trouble. The DSM just gives us a common language. It allows for communication and research and billing and coordination of care. But it doesn't map etiology. It doesn't really tell you why this person is suffering. It tells you how they're suffering. It gives you clusters relative to others. So this is where I want you to begin holding some productive tension in your mind. We will use the DSM because that's what clinical practice requires. But underneath it, we're going to think more deeply. And this is where that framework like the RDoC comes in. It's not as a replacement, but as a thinking tool. RDoC asks different questions. RDoC, research domain criteria, ask you what systems are involved to manifest those symptoms. What domains are dysregulated? What functions are altered across diagnoses? Those questions will help you think. They don't just absolve you from clinical judgment. And here's the key point I want you to hear clearly. Psychopharmacology does not treat diagnoses. It treats symptoms and systems. That's why the same medication can appear across widely different diagnoses. That's why the response is so variable. And that's why correlation can fool us into thinking we've explained something when we've only observed an effect. So when you ask, what is mental illness? I want you to resist those simple answers. Mental illness is not a single thing. It's a pattern of suffering that exceeds a person's current capacity to adapt, shaped by biology, experience, and context. So our role is not to declare certainty. Our role is to intervene thoughtfully. And you want to reduce suffering and help patients build capacity over time. Because the moment you forget that this is all theoretical, the moment you confuse models with reality, you risk practicing psychiatry with confidence that greatly outpaces our understanding in the field. Now, this table is here to normalize something that many of you may have begun to sense. So even if you don't yet have the language for it, psychopharmacology feels different from the rest of medicine because it is different. Now, let me walk you through this a little slower. So start with the first row, understanding. With most non-psychiatric medications, we can point to a relatively direct physiological process. We can say this enzyme is inhibited, this receptor is blocked, this hormone increases. In psychiatry, our understanding is often only partial or theoretical. That doesn't mean random, it just means incomplete. We're working with the most complex organ in the body, embedded in learning, memory, trauma, culture, and meaning. And we're expecting clean, mechanistic explanations here. That's kind of naive. So look at the phrasing of mechanisms of action. Notice the language we use in psychiatry. When you look up the medication's mechanism of action, you will see things that says believed to, hypothesized to, thought to, may act by. That language isn't sloppy, it's honest. Contrast that with non-psychiatric medications where we can often say directly inhibits, binds to, blocks production of, increases secretion of. Those statements reflect different levels of causal certainty. So here's the trap. If you hear tentative language and assume weakness, you're going to miss the sophistication required to practice psychiatry well. Next is the level of complexity. So psychiatric medications target networks, not single pathways. They target circuits and feedback loops and adaptive systems. That's why two patients with the same diagnosis can respond in opposite ways to the same medication. In contrast, many non-psychiatric medications act on processes that are better mapped and more stable and more predictable across people. Which brings us to this concept of measurable effects. In psychiatry, improvement is often subjective, right? Better mood, better cognition, better motivation, less internal distress. Those are real outcomes, but they're harder to quantify biologically. So in much of medicine, effects show up as numbers: blood pressure, glucose, lab value, electrical signals. This doesn't make psychiatry outcomes less real, but it does make them harder to study and easier to misinterpret. Now, the other thing to consider here is look at the variability. Psychiatric response is highly variable because it's shaped by biology, one, development, trauma, personality, relationships, environment. The same molecule enters two nervous systems and does not encounter the same terrain. That's not a failure, that's context. We'll discuss that in a subsequent lecture when we talk about the concept of moderators. Finally, we have this issue of research challenges. Psychiatric research is hard, not because they're careless, but because a diagnosis are constructs. Outcomes are probabilistic. And placebo effects are very powerful. And human meaning also can't be controlled for very cleanly. So this is why correlation can feel so convincing and why it's so often misleading. So here's the takeaway I want you to hold on to. Psychiatric medications are not necessarily inferior versions of real medicine. They're tools designed for a different kind of problem, and because of that, they demand slower thinking and clearer communication and stronger ethical grounding and a lot more humility. So if you approach psychopharmacology expecting certainty, you're most likely going to get very frustrated. And if you approach psychopharmacology expecting trade-offs, then you'll be okay and practice it well. Alright, so if you take nothing else from today's lecture, take this. Most clinical errors in psychiatry come from confusing correlation with causation. Correlation simply means that two things move together. When one changes, the other tends to change as well, and that's it. Correlation does not tell you which came first, or which caused which. Whether something else caused both, or whether the relationship is even meaningful. And yet our brains desperately want it to be so. So here's the classic trap in clinical practice. The patient starts a medication, the patient improved, therefore the medication caused the improvement. Sometimes that's true. Often it's not. Symptoms by nature fluctuate. Regression to the mean is real, and placebo effects are powerful. Contexts change. So patients want to please you as their clinician. So clinicians want to feel helpful. This is why smart, well-intentioned clinicians often fool themselves. Now contrast that with causation. Causation means that one variable directly produced the change in another. That's a much stronger claim, and it requires much stronger evidence. This is where tools like the Bradford Hill criteria come in. These criteria don't prove causation, but they help us ask better questions. Did the exposure precede the outcome? Is the association strong and consistent? Is there a plausible mechanism? Is there a dose-response relationship? Notice what's missing in these questions. The certainty. So even with rigorous criteria, causation in psychiatry always remains probabilistic. Now let's talk about some logical fallacies too, because clinicians are not immune to them. even if they're really educated. The most common one you're going to see committed is this post hoc ergo propter hoc. After this, therefore, because of this. So a patient takes an SSRI and the patient feels better 6 weeks later. Conclusion, serotonin deficiency is corrected. Right? That leap feels reasonable. It's often wrong. Another major issue are that of confounding variables. Maybe the patient started therapy since they've started your medication. Maybe they left that toxic relationship or that bad job. Maybe in the meantime they've got stable housing, or they reduced their substance use, or enough time has passed that they got a better perspective. But the medication's getting the credit. Why? Because it's visible, it's concrete, and it was prescribed by you. So this is why psychiatry demands a lot of intellectual restraint. We don't deny that medications help. We deny the claim that improvement automatically explains causation. And here's the uncomfortable truth. The more emotionally invested you are in helping, the more vulnerable you are to confusing correlation with causation. It's not a character flaw, that's just normal human cognition. Your job as a clinician is not to eliminate that bias, it's just to notice it and slow down and compensate for it. And this is also why anecdote is such a dangerous teacher, and the most dangerous words in medicine are, in my experience. You'll remember dramatic success. You'll often forget those quiet non-responders, and you will rationalize side effects as worth it. Without discipline, though, experience can make you less accurate, not more. So I want you asking yourself over and over and over and over again, what else could explain this change? What assumption am I making? Am I observing an effect or explaining it? That mindset will not make you indecisive, it'll make you a lot safer. So I'm spending more time on this, correlation versus causation. This is such an important concept to distinguish that I want you to pause before answering it, because how you answer this question will quietly shape how you prescribe for the rest of your career. Now, you're given 4 answer choices here. Let's walk through these. Not like a test taker, but as a clinician. So option A, correlation always leads to causation. That one's tempting when you're tired and rushed and emotionally invested in helping someone, but it's categorically false. If correlation always meant causation, psychiatry would be easy, and it isn't. Option B, causation can only be determined by meta-analysis. Sounds sophisticated, but also wrong. A meta-analysis can strengthen your confidence in associations, but they don't magically solve the causation problem, especially when the underlying studies are heterogeneous and the outcomes are subjective and the diagnoses remain constructs. Meta-analysis aggregates uncertainty. It doesn't eliminate it. What about option D? Causation is irrelevant in psychiatric treatment. This is dangerous in a different way. If causation were irrelevant, then anything that coincided with improvement would be fair game. Rituals, superstitions, polypharmacy, all without rationale. So we don't need perfect causal explanations to treat, but we absolutely need causal humility. Which brings us here to option C. That's the correct answer. Correlation shows an association, but not a direct causal relationship. Now here's the important part. Choosing C is not just about being statistically correct. It's about protecting patients from our own cognitive shortcuts. Because if you assume causation where there is only correlation, you are likely going to overprescribe and escalate unnecessarily and misattribute side effects to illness, and you're going to resist deprescribing even when it's warranted. And you're also going to start to believe stories about mechanisms that feel explanatory but are only loosely connected with reality. This is why early clinical confidence must be paired with restraint. So you're only allowed to act on correlations. You're not allowed to confuse them with proof. And in psychiatry, you need to know that we're often going to act with incomplete information and probabilistic beliefs and uncertain mechanisms, and it's acceptable in this field. What's not acceptable is pretending that uncertainty doesn't exist. So when you choose option C here, what you're really saying is, I will use evidence without worshiping it. I will treat patterns without inventing certainty. I will stay open to being wrong. And that mindset is not weakness, that's clinical maturity. And as you head into your rotations, this distinction is going to constantly keep coming up. When a patient improves, when a medication stops working, when side effects are subtle, and when someone wants just one more adjustment, every time I want this question echoing quietly in your mind. Am I observing a relationship or telling myself a story about cause? All right, up until now we've talked about correlation and causation conceptually. Now we're going to anchor this in some real-world reasoning, the kind you'll need when you start practicing. So let's start with this first distinction. Correlation identifies statistical associations, and that's it. It tells us that two things tend to appear together. For example, people with depression often have altered sleep. People taking antidepressants often improve over time. People with severity anxiety often report gastrointestinal symptoms. All of those are correlations. They are observations, not explanations. Causation, by contrast, requires evidence of direct influence. That's a much higher bar. In order to claim causation, you need to show that one thing doesn't just coexist with another, but actually produces change in it. This is why we care so much about this concept of temporal precedence. The cause has to come before the effect. If improvement begins before the medication reaches a therapeutic level, that should immediately slow your conclusion. The next thing we need to focus on is the strength of the association. A weak association can still be real, but it needs to temper your confidence. So in psychiatry, many effects are statistically significant, but clinically modest. That doesn't make them useless, but it does make them easy to overinterpret. Then there's these things of ruling out confounders, which is one of the hardest things to do in mental health. So was it the medication, or was it time and therapy and safety and validation and structure and therapeutic alliance and reduced chaos? Often it's several of these at once. So this is where that Bradford Hill criteria comes in. I want to be very clear about what these are and what they're not. They are not checklists that magically prove causation. They're just a thinking framework to help you judge whether a causal claim is becoming more plausible. So let's walk through a few of these. So strength of the association. Stronger, more consistent effects raise your confidence, but they don't guarantee causation. Consistency. Do we see similar findings across different studies of populations and settings? Specificity. Is the exposure linked to a particular outcome or to everything vaguely? Psychiatry often struggles here because many interventions affect multiple domains. The other concept we need to talk about here is temporality. So this is the non-negotiable. The cause has to precede the effect. If temporality isn't clear, causation collapses. The other thing to consider here is dose-response relationship. So does more exposure lead to more effect? In psychiatry, this is often imperfect and nonlinear and absent. So this, again, needs to slow down our certainty. The other thing is plausibility and coherence. Does the proposed explanation fit with what we already know about biology, psychology, and behavior? This is where that neurochemical fairy tale can sneak in. Mechanisms that sound scientific but explain very little. The area of what we call biobabble. Do things change when the exposure is introduced or removed. That's the experimental phase. This is where deprescribing can be as informative as prescribing. And finally, we have to consider, are there alternative explanations? This is the criteria that clinicians most often skip because it's uncomfortable. Asking what else could explain this threatens our sense of mastery. But it's the question that protects patients. So let me pull this together for you. In psychiatry, causation is rarely proven in a clean, linear way. Instead, we accumulate converging evidence, always provisional, always incomplete. So that means your job is not to demand certainty before acting. Your job is to act while knowing how fragile your explanation may be. That's the balance. Correlation gives you signals. This Bradford-Hill criteria may help you interrogate those signals, but your clinical wisdom lives in knowing when to act and when to doubt your own story. So now we're going to start applying this directly in the psychopharmacology research and why even randomized controlled trials don't rescue us from this responsibility of thinking. All right, now this slide looks technical, but it's actually one of the most clinically important slides in this entire lecture, because every time you use a rating scale or a screener or an outcome measure, you're making a quiet claim about what you think is real. So let's start with this concept of reliability. Reliability is about consistency. It answers the question, if I measure this again, do I get roughly the same answer? And there are a few different ways that consistency shows up. You can have test-retest reliability, and that asks, if nothing meaningful has changed, does the score stay stable over time? So if a patient takes the PHQ-9 and swings wildly week to week with no clinical explanation, that's a measurement problem, not an insight. Another concept is inter-rater reliability asks, if two clinicians assess the same patient, do they reach similar conclusions? That matters enormously in psychiatry because where observation and judgment play the largest role. And what about this concept of internal consistency? Well, this asks the question, do the items on the test actually hang together? Are they measuring one thing or a grab bag of loosely related symptoms? So here's the key point. A measure can be highly reliable and still be wrong. And that brings us to validity. Validity is all about accuracy. So this answers the harder question. Is this tool measuring what we think it's measuring? And there are different flavors of validity, and each one matters clinically. The first thing is content validity. This asks the question, does the test cover the domain it claims to assess? So if we say a scale measures depression, but mostly captures sleep and appetite, we should be cautious about what conclusions we draw. Another form of validity is construct validity, and this asks the question, does this tool actually reflect the underlying concept like depression, anxiety, cognitive impairment? Remember what we said earlier, these constructs are all theoretical. They're not directly observable. So that makes validity especially fragile in psychiatry. Another form of validity is predictive validity, and this asks the question, does this score tell us something useful about what happens next? For example, risk, relapse, response. This is where the tool either can earn their keep or we throw it out the window. There's another form of validity called concurrent validity, and this asks the question, does this measure line up reasonably well with other accepted measures taken at the same time? So how do we bring all this into practice? Well, Look at the right side of the slide. You're going to see some familiar names. PHQ-9, GAD-7, QIDS, GDS, HAM-D. These tools are not truth machines. They are imperfect instruments designed to standardize your communication. They track change over time. They're intended to support, not replace, your clinical judgment. They're included in neuropsychiatric batteries not because they're flawless, but because they are useful enough when used thoughtfully. The clinical trap I want you to avoid is that high reliability can create false confidence. If a score is consistent, it feels objective. If it's numeric, it feels precise. But, as you know and have heard me say, feelings are not facts. So a number can be consistently wrong about the thing that actually matters to the patient. So your clinical stance needs to be, use the scales to inform your thinking, not to outsource it. You want to track trends, not absolutes. You want to interpret the score in context, not in isolation. And you always want to ask yourself, what does this measure capture well? And what does it miss? And how might that shape my prescribing decisions? Because when you confuse measurement with reality, you stop listening to the patient. And in psychiatry, that is where harm begins. Now this slide looks simple, but this is where a lot of clinicians get tripped up. So let me make a clean distinction because this matters in real practice. Reliability is about consistency. It answers the question, if I measure this again, do I get roughly the same results? So when we look at tools like PHQ-9 is reliable, like we said on the last slide, we're asking the question, if the patient's symptoms haven't changed, then the score should not bounce around randomly. Reliability can show up across time or across different clinician ratings for the same patient. A reliable tool is stable, but stability alone does not make it true, and that's where validity comes in. So validity, like I said, is about accuracy. It answers the much harder question as, is this tool measuring what I said it's supposed to measure? A depression scale should measure depression. Not anxiety, not stress, not insomnia alone. So a tool can be reliable, but not valid. You can measure the wrong thing very consistently. And in psychiatry, this happens more often than we're comfortable admitting because our constructs are all abstract and they're overlapping and they're laden in theory. And this is where that humility thing comes in again. When you look at a score, you should be asking yourself, what construct is actually captured? What assumptions are baked into this tool? What might it miss in this patient in this context? This is why rating scales are aids. They're not arbiters. They help you. They help you track trends and communicate with other clinicians and document response. But they should not replace your clinical reasoning or your longitudinal observation or the patient's lived experience. So your stance is not so much skepticism versus blind trust, it's disciplined use. You use reliable tools, but you need to interpret them cautiously and value validity, but you need to recognize its limits. And always remember, precision is not the same as truth. Okay, so here's a question that you may see in the future, say on your midterm, but I want you to hear this in terms of a clinical reasoning question in this lecture, not as a test trick. So the stem of the question says, a diagnostic tool produces consistent results, but fails to identify actual cases of depression. Right away, two different concepts are being tested here. Produces consistent results tells me about reliability. Consistency over time, across raters, across settings, that's high reliability. But then comes the critical phrase, fails to identify actual cases of depression. That's not a reliability problem, that's a validity problem. Specifically, this is a problem of construct validity. The tool is not measuring the construct it claims to measure. So let me run through these answer choices with you. Option A, high validity, low reliability. No. If this were highly valid, it would correctly identify depression. What about option B? low validity, low reliability. No, the STEM told you that the results are consistent. What about option C? High reliability, low validity. Yes, this is the uncomfortable but very real scenario in psychiatry. A tool can be internally consistent, reproducible, statistically elegant, and still wrong about what it's measuring. And what about option D? High validity, high reliability. Again, no, because it fails to identify true cases. So the correct answer here is C, high reliability, low validity. So here's the bigger lesson though, the one that matters more than the exam. In psychiatry, we often reward reliability because it's easier to demonstrate and produces cleaner statistics and gives you tighter confidence intervals and prettier psychometrics. But validity is messier. It forces you to ask the harder question. What is depression? Where does anxiety end and where does depression begin? Are we measuring symptoms, distress, impairment, biology, social suffering? This is why I'm asking you to hold these two ideas at once. You got to respect these tools, but don't worship them. A scale that gives you the same number every time may feel reassuring, but if it's measuring the wrong thing, it can mislead you with confidence. Even long before AI came along. So that's more dangerous than uncertainty. So when you see a score in a clinic, your inner voice should quietly ask, reliable, but is this valid for this patient right now? That habit right there, that's what's going to separate the technician from the professional. All right, I want you to listen to this case study, and this is maybe how it appears in clinic. Don't listen for this, though, not as a checklist, but as a story. So we have this 32-year-old woman that comes in with fatigue and difficulty concentrating and trouble sleeping for about 2 months. So these 3 symptoms alone could point you in many different directions. You might be tempted to jump on depression, anxiety, medical illness, burnout, sleep disorder, life under strain. But then she adds persistent worry about work performance, irritability, muscle tension. Now that cluster of symptoms should start nudging your thinking not to a diagnosis yet, but to a domain, right? This sounds like sustained arousal, cognitive load, muscle tension, anticipatory worry. She denies panic attacks, suicidal ideation, substance use. Well, that's good because this helps us rule out some other things, but notice it doesn't rule in anything. Her hypothyroidism is well controlled, which matters, but it doesn't let us stop thinking. Controlled on paper doesn't always mean irrelevant in practice. Now here's the thing you need to notice. We're told that the following tools are used. The PHQ-9, the GAD-7, the HAM-D. So let me ask the question I want you to ask yourself. What are these tools for? And what are they not for? See, the PHQ-9 is optimized for depressive symptom burden. The GAD-7, that's for generalized anxiety symptoms. The HAM-D, that's for a clinician-rated scale that historically weights sleep and somatic symptoms heavily. So here's the tension now. The patient's symptoms overlap constructs, right? You have fatigue, poor concentration, sleep disturbance. All of those will inflate the PHQ-9 and a HAM-D score, even if the core pathology is anxiety rather than depression. So if her PHQ-9 comes back moderate depression, the question is not, is the score valid? The real question is, valid for what? So this is where reliability and validity stop being academic terms and start becoming clinical safeguards. The scales are reliable, but they're not diagnostic truths. They help you structure the interview, track change over time, communicate severity, but they don't decide what the primary disorder is, or what mechanism is driving the symptoms, or what treatment should come first. So before we even talk about medications, you have to ask yourself, which construct is most active here? Is this distress driven by negative valence, arousal, cognitive load? Are we seeing depression or demoralization secondary to anxiety? Those are reasoning questions, not scoring questions. And the bigger lesson is, if you treat the score, you may over-medicate. And if you treat the syndrome, you'll be closer, but still imperfect. If you treat the person using scores as a guide rather than rulers, well, now you're going to practice with integrity. So we're not here to cure anything today. We're here to reduce suffering, build capacity, and avoid doing harm with false certainty. So on paper, depression and anxiety look like distinct diagnoses. But in real life, patients don't read the DSM. So let's take a walk through this slowly and honestly. Look at the left column here, the symptom of fatigue. In depression, patients describe it as I'm drained or everything takes effort. In anxiety, it's different because they'll say things like I'm exhausted because my body never shuts off. Same symptom, different mechanism. Now let's look at difficulty concentrating. In depression, concentration fails because motivation is low. Cognitive slowing is real. Rumination pulls the attention inward. But in anxiety, concentration fails because attention is hijacked by worry. The brain is scanning for threat. Working memory is overloaded. Same complaint, different neurocognitive load. What about sleep disturbance? Another classic overlap. So depression can cause early morning awakening or hypersomnia or fragmented sleep tied to a circadian dysregulation. Whereas anxiety causes difficulty falling asleep, racing thoughts, physiological arousal at bedtime. If you only count hours slept, you miss the point entirely. Now, what about something like irritability? Well, depression-related irritability comes from frustration or emotional blunting or low tolerance for demand. Whereas anxiety-related irritability can come from heightened arousal, sensory overload, or a nervous system already at capacity. Same behavior, different nervous system. Now look carefully at something like muscle tension. This is where the pattern recognition starts to matter. Muscle tension is uncommon in primary depression. Common and diagnostically meaningful, though, in generalized anxiety. This is a body clue. Psychiatric diagnoses will ignore the body at its peril. So persistent worry is another anchor. Depressed patients may worry, but it's usually episodic and tied to specific losses or failures. Whereas anxiety is different. Worry is persistent and diffuse. It's future-oriented. It's self-perpetuating. That's not just a symptom, that's a defining process. We'll contrast that with the hopelessness, and hopelessness is not just sadness. It's a loss of future orientation, a collapse of perceived possibility. That's much more specific to depression. And finally, suicidal thoughts. These are not anxiety symptoms. When they appear in anxiety disorders, it's usually because the depression is also present. And this brings us to the central teaching here. Overlap in symptoms does not mean overlap in pathology. And that's why rating scales can mislead you. A PHQ-9 will light up for fatigue, sleep, concentration, irritability. A GAD-7 will light up for many of those same items. So if you simply total the scores and pick the highest one, you're going to mislabel the patient. You're going to overprescribe. You're going to misunderstand what they're actually experiencing. So that's clinical reasoning. You're not asking which diagnosis fits best. You're asking what process is dominant right now. Is this negative valence and hopelessness? or sustained arousal and threat anticipation, those treatment implications differ. And here's that humility that needs to keep coming back. Many patients live in that overlap. Some don't need a perfect label, they just want symptom relief. They want nervous system stabilization. So a clinician who understands trade-offs, we're not curing depression or anxiety, we're just mitigating suffering. We're increasing capacity. We're avoiding harm that's born out of false certainty. So if you've been around psychiatry, this slide should look somewhat familiar to you, and that's exactly why we need to talk about this very carefully. So you have likely seen some version of this chart, right? Dopamine does this, serotonin does that, GABA calms, and norepinephrine activates. So here's my first question to you. Is this chart wrong? No, but it is dangerously incomplete. So let's start with dopamine. We say dopamine is about reward, motivation, and motor control, and that's all true. But it's also a massive oversimplification. Dopamine is not a reward chemical, it's a salience and prediction system. It helps your brain decide what matters, what to pursue, what to ignore. That's why dopamine loss causes Parkinsonism. Dopamine excess in certain circuits contributes to psychosis. And dopamine dysregulation shows up in addiction, ADHD, and negative symptoms. Same neurotransmitter, different circuits, different clinical realities. So this is your first warning against the one-to-one thinking. Now, let's look at serotonin. We love to say it regulates mood, anxiety, and sleep. And that's partly true. But serotonin has at least 14 receptor subtypes, often doing opposite things depending on location. So when someone says SSRIs increase serotonin, therefore they improve mood, that's not a mechanism, that's a slogan. SSRIs change downstream signaling, alter plasticity over time, and may reduce emotional reactivity rather than quote-unquote fix depression. Which is why some patients feel better, some patients feel blunted, some feel worse. Same drug class, different nervous system. Now what about GABA? This one feels clean, right? Inhibition, relaxation, anxiety reduction, and benzodiazepines do exactly that. Acutely, but here's the trade-off. Develop tolerance, dependence, cognitive dulling, interference with learning, and trauma processing. So when you use a GABAergic drug, you're not just reducing anxiety, you're making a time-limited bargain with the nervous system. It's helpful sometimes, but it can be harmful if it's misunderstood. Now let's talk about norepinephrine. We get arousal, alertness, and stress response, and this system is about energy mobilization. If they have too little, the patient feels slowed and apathetic and cognitively foggy. If they have too much, they feel keyed up and anxious and hypervigilant. So SNRIs don't just treat depression, they shift the balance of activation, which is why they can help some depressed patients get moving. They can push some anxious patients over the edge, though. Same medication, different baseline state, different outcome. Now let me zoom out and say the most important thing about this slide. This chart invites this seductive false conclusion. If I match a symptom to the neurotransmitter, I'll pick the right drug. That's not psychopharmacology. That's like pharmacologic astrology. In reality, neurotransmitters operate in networks. Medications affect systems, not switches. And clinical outcomes emerge over time, not immediately. This chart is starting to map, not the territory. This helps you organize your thinking, communicate some concepts, and avoid total chaos. But if you treat this as a prescription guide, you're going to overestimate certainty, underestimate trade-offs, and you're going to fool yourself with clean narratives. That brings us back to that through line of this course, by the way. which is psychopharmacology is not about curing diseases. It's about mitigating symptoms, improving function, and doing so without pretending that we fully understand the machinery. So if you leave this lecture thinking, wow, this is a lot simpler than I thought, then I have failed. If you leave thinking I need to think more carefully than I realized, then you're in the right spot. All right, well, this slide looks straightforward, right? Pharmacology question? It is, but I want you to hear why the obvious answer is correct and what it quietly leaves out. So let's read this stem carefully. We're being asked why a GABA agonist like lorazepam helps with anxiety. Now, before we even look at the answer choices, ask the upstream question. What is anxiety at the level of the nervous system, right? Anxiety is not sadness. Anxiety is not low mood. It's excessive neuronal excitability, particularly in circuits involved in threat detection, arousal, and anticipation, right? So in plain language, the brain is firing too much, too fast, for too long. Now with that in mind, let's evaluate our answer choices. A, it increases excitatory signaling in the brain. And that would make anxiety worse, not better, so that's not the right answer. Option B, it enhances inhibitory neurotransmission, reducing neuronal excitability. Now that should immediately feel right. GABA is the brain's primary inhibitory neurotransmitter. Its job is to apply the brakes. Lorazepam doesn't create calm out of nowhere. It lowers the volume of the neuronal firing across multiple circuits. So the correct answer is B. But let's not stop there because this is where the clinical reasoning matters. Option C, it blocks dopamine receptors, calming the reward system. That's what antipsychotic logic is, not anxiolytic logic. What about option D? It stimulates serotonin release, improving mood. That's more SSRI territory, and importantly, serotonin modulation works slowly, not acutely. So here's the part I want you to hold on to. Benzodiazepines work because they enhance inhibition, reduce arousal, and rapidly quiet the nervous system. That's why they feel effective. That's why patients ask for them. That's why clinicians are tempted to overuse them. But at the same mechanism that makes them powerful also creates that trade-off of tolerance and dependence and cognitive dulling, and it interferes with learning and fear extinction. So clinically, lorazepam is not anti-anxiety medication in the broad sense. It's arousal-reducing medication. That distinction matters. And it can be extremely helpful for short-term, situational, or as a bridge. It can be harmful when used as a long-term solution, or as a replacement for adaptive coping, or as a way to avoid addressing underlying drivers. So the exam answer here is B, but the answer that you need to have in clinical practice has to be more nuanced. GABA agonists reduce anxiety by suppressing neuronal excitability, but they do so at the cost of learning and memory and long-term resilience. So it's that kind of sentence that you should be able to say to yourself and to your colleagues and eventually to your patients. So as we move forward in this course, I want you to practice holding both truths at once. The mechanism will explain the benefit, but the mechanism also explains the harm. And psychopharmacology lives in that tension and drives home the point of trade-offs. Now, this slide tells us about who comes to care and why. All right, this is a big concept in psychiatric symptomatology. This is the one that's going to help you make sense of symptoms long before you make sense of a diagnosis. Let's start simply by noticing that externalizing and internalizing are not diagnoses. They're just directions of distress. They tell us where suffering goes, not what the disorder belongs to. So externalizing features, these are symptoms that are outwardly directed. The distress doesn't stay contained in the individual, it spills out into society. So we see behaviors, it spills into the environment, it affects relationships. So externalizing are things like impulsivity, aggression, hyperactivity, substance use, rule breaking, acting out. These patients tend to do their symptoms, right? And because their distress is visible, they are noticed sooner. They get labeled faster. They're often disciplined before they're understood. Clinically, externalizing patterns will often map onto things like, say, disinhibition or reward dysregulation or impaired top-down control, right? They stress the system around them. Whereas internalizing features, these are symptoms that are inwardly directed. The distress turns against the self. Think of things like anxiety, depression, rumination, guilt, shame, withdrawal, somatic complaints. These patients tend to carry their symptoms quietly, right? Contained within them, which means they're often praised for coping. They're often overlooked in systems, and they're often undertreated until the symptoms are severe enough. So clinically, internalizing patterns reflect this heightened threat sensitivity and that negative valence bias, that overactive self-monitoring. These people with internalizing symptoms, they suffer privately. Why this distinction matters is because the two patients can have the same diagnosis and a very different symptom directionality. And the two patients can have different diagnoses, but the same internalizing or externalizing profile. And why this matters is because externalizing patients often need containment and structure first, whereas internalizing patients often need safety and permission to externalize their distress. It also matters psychopharmacologically because medications that reduce inhibition may worsen externalizing behaviors. They may increase activation and may worsen internalizing anxiety. They may blunt affect or may quiet behavior but deepen that internal suffering. So before you ask what diagnosis is this, you need to ask what is this person's distress pointing at? Which direction is it going? Is it going outward or inward? That question alone will sharpen your formulation and temper your prescribing and help you avoid misreading silence as stability. So as we move forward, you're going to see this framework reappear, sometimes explicitly and sometimes quietly, because this cuts across all the DSM categories and aligns much more closely with how patients actually live, how their symptoms manifest. This is not about labels, this is about pattern recognition. And pattern recognition is where your wisdom will come from. Now, the STEM asks you for the best differentiator between externalizing and internalizing disorders. So we're not looking for moral judgments or severity or ease of diagnosis. What we're looking for here is direction of impact. So let's walk through the options here. Option A, externalizing disorders primarily impact the individual's internal world. That's actually the definition of internalizing. So this is backwards and wrong. Option B, internalizing disorders are outwardly disruptive and aggressive. Again, reversed, obviously, wrong answer. Internalizing disorders tend to be quiet, inward, and often invisible. What about option C? Externalizing disorders involve behaviors that impact others or the environment, and that is the key distinction. Externalizing disorders are characterized by behaviors that spill outward and disrupt systems and affect relationships in school and workplaces and families. The suffering is real, but it's expressed behaviorally and often affects others first. So C is the correct answer. Now what about D? Internalizing disorders are always easier to diagnose. This is almost never true. In fact, they're often the hardest to diagnose because the distress is hidden and minimized and somatized. Externalizing disorders will get attention early. They trigger consequences. They provoke interventions. Whereas internalizing disorders are often tolerated, normalized, or praised as coping until they become very severe. The difference has nothing to do with intelligence or strength or insight, but it has everything to do with where the distress goes. So outward, externalizing. Inward, internalizing. And why this matters is because if you only treat what disrupts the room, you overtreat those externalizing behaviors and undertreat the internal suffering ones. And if you only treat what's reported verbally, you're going to miss patients who don't yet have the language for their distress. So when you answer this question correctly, C, you're not just passing an exam, you're learning to ask better clinical questions. Who's paying the price for this person's symptoms right now? The environment or the patient themselves? That question is going to help sharpen your assessment and guide your interventions and keep you from confusing silence with wellness. All right, meet Emma. Notice how quickly your mind wants to jump to the answer here. We're told that she can't sit still and is constantly interrupting. She forgets to finish tasks and seems disorganized. Already, most of you are thinking the same thing, right? Good. That means the pattern recognition is working. But don't answer yet. Let's put in the additional history because context here is everything. Her symptoms are present at both school and home. They are ongoing for more than 2 years. She's associated with losing items and blurting out answers before the questions are finished. This is not episodic. This is not situational. This is not confined to one environment. This is pervasive and developmentally persistent. So let me ask this question out loud. What diagnosis do you suspect and why? You're probably yelling at the screen thinking ADHD with combined presentation. Why? Because she's hyper. Not because she's distracting, but because the core deficits are present: impaired sustained attention, poor executive function, impulsivity, symptoms across multiple settings, and a chronic course. Those features matter far more than energy level alone. So here's the critical point. This is an externalizing presentation. Emma's distress is showing up as disruption, interruption, unfinished tasks, lost materials. The environment is impacted before Emma can articulate internal distress. That makes ADHD visible. It also makes it vulnerable to misinterpretation, because here's what ADHD is not. It's not willful defiance. It's not poor parenting. It's not simply anxiety, though anxiety may coexist. This is not a moral failure of attention. ADHD is a disorder of executive control and temporal organization and reward prediction. Now let me slow you down a little bit more. Even though ADHD is the most likely diagnosis is not the same as decision. So before treatment, you still need to ask, are there sleep problems? Is there trauma? Is anxiety driving the restlessness? Is the learning environment mismatched? You see, good clinicians don't just identify the pattern, you also have to rule out the competing explanation. And when it comes to psychopharmacology, this matters enormously because stimulants can be transformative when the formulation is correct. It could be destabilizing when the formulation is wrong. So the mature stance is this: I suspect ADHD because the pattern fits, but I will confirm thoughtfully and treat cautiously and reassess continuously. This way, Emma and you are both protected. All right, now we have Noah. So I want you to notice how different your internal reaction feels compared to Emma. So Noah is a 10-year-old boy with stomach aches, frequently crying before school, and a parent who's worried but not describing any disruptions. Already this case feels quieter, but quiet doesn't mean benign. So let's go through this. His key complaints include he worries constantly about tests, even if he's prepared. He asks endless what-if questions about bad things happening. This is not distractibility. This is not impulsivity. This is not failure to finish tasks. This is anticipatory distress. Now, the additional history says persistent worrying for more than 6 months, sleep disturbance with nightmares, avoidance of school presentations due to fear of embarrassment. This is the moment where good clinicians separate anxiety from performance, because Noah is not underperforming. He's over monitoring. So what diagnosis do I suspect here? Well, the most likely diagnosis is generalized anxiety disorder with features of school avoidance and somatic anxiety. But why? Well, because the core pattern is what? Excessive worry, difficulty tolerating uncertainty, physiologic arousal expressed somatically, and avoidance driven by fear, not inattention. Now let's make the contrast explicit. Emma externalized distress. Noah internalizes it. Emma disrupted the environment. Noah absorbs the distress into his body. Emma lost her pencils. Noah gets stomach aches. Same age range, very different neurobehavioral logic. And this is where you can get into trouble, because the internalizing disorders don't trigger referrals as quickly. They don't exhaust teachers. They don't break classrooms. They quietly erode the functioning from the inside. So if you treat Noah as if he has ADHD, for example, by stimulating an already hypervigilant nervous system, you may worsen his symptoms. If you treat Emma as if she's just anxious, you may miss the executive dysfunction entirely. Same setting, different brain, different risk. So what's the underlining larger lesson here? These cases are not about memorizing criteria, they're about reading the patterns of adaptation. Anxiety is not simply fear, it's a strategy for managing uncertainty. ADHD is not simply laziness, it's a disorder of temporal control and reward signaling. Both are attempts by the brain to cope, and neither is a moral failure. But the correct stance here is not certainty, it's that disciplined humility. So I suspect that generalized anxiety disorder because the pattern fits. I will still assess for learning disorders, trauma, family stressors, depression, and I will intervene in a way that builds tolerance, not avoidance. So that's the through line here. We're not curing brains, we're mitigating suffering, we're increasing capacity, we're helping patients function in a world that will not simplify itself for them. So this is a fairly simple slide, but it's how misdiagnosis can frequently happen. So I want you to resist reading this as a checklist, but instead I want you to read this as two different failure modes of attention. So let's start with the first row. So the attention issue. In ADHD, attention fails because it will not lock on. The brain is scanning for novelty and reward and stimulation. But in generalized anxiety disorder, attention fails because it's already occupied. The bandwidth is consumed by worry. And both look like can't focus, but only one improves with stimulants. Next, take a look at the physical symptoms, and this is a critical differentiator. So ADHD is largely cognitive and behavioral. Physical symptoms are often minimal unless the frustration escalates. Whereas in generalized anxiety disorder, by contrast, this lives in the body. So they'll report things like muscle tension and fatigue and headaches and GI complaints. So if the parent brings you stomach aches, chest tightness, sleep complaints first, your antenna is going up for anxiety. Now look at mood. ADHD mood dysregulation is reactive, right? It flares up when tasks are boring, frustrating, or demand sustained effort. Whereas generalized anxiety disorder mood is anticipatory, and the distress comes before the task even begins. And that timing matters. Now the time frame, ADHD is typically lifelong, and parents will say she's always been this way, even if they didn't have a language for it at that time. Whereas generalized anxiety disorder, especially in children, evolves with development. So the worries will change as the child's cognitive capacity changes. So a 6-year-old worries about separation. A 10-year-old worries about tests. A teenager worries about identity performance. Same disorder, different content. And then finally, note the triggers. So ADHD is triggered by boredom and low stimulation and tasks without immediate reward, whereas generalized anxiety disorder is triggered by uncertainty, evaluation, imagined future outcomes. So the clinical shortcut I want you to remember is that if a child avoids a task because it's boring, think ADHD. But if a child avoids a task because it's threatening, think anxiety. Now here's the caveat, of course. These disorders frequently co-occur. And when they do, anxiety can mask ADHD. Or ADHD can generate anxiety through repeated failures. So that's why diagnosis is not about picking which column. It's about determining which process is primary. And here's something to keep in mind for your final exam. ADHD is a disorder of regulation, whereas generalized anxiety disorder is a disorder of anticipation. So if you can hear that distinction in your patient's story, you're already ahead of most clinicians. Well, why do we need frameworks at all? So let's start with what you already know and what you will actually use in practice. So the DSM-5, that is our symptom-based classification system. It answers a very practical question. Does this patient meet criteria for a diagnosis that I can document, bill, and treat? And to be clear, that matters, right? You can't opt out of the DSM in a real-world practice. Insurance companies and clinical documentation and board exams and treatment guidelines all assume DSM categories. So the DSM is not wrong. It's instrumental. But here's the tension. The DSM tells you what cluster of symptoms a patient has. It does not tell you why those symptoms exist. Now let's contrast that with the RDoC, the research domains criteria. Now that's not a diagnostic manual. It's a dimensional neurobiological research framework. So instead of asking which disorder is this, RDoC will ask which underlying systems are dysregulated and in what direction. So what do I mean by systems? Where you can have threat systems, reward systems, cognitive control, arousal, social process. RDoC treats pathology as gradients, not boxes. So the key point I want you to hear carefully is that RDoC is not meant to replace the DSM in clinical practice. It's just meant to discipline your thinking. So think of it this way. The DSM will give you a label. The RDoC is designed to give you a map. So the DSM says this looks like major depressive disorder. RDoC will ask you, is this primarily a negative valence problem, a reward processing problem, a cognitive control problem, or a mixed picture? And that distinction matters because medications do not treat diagnosis, right? They modulate circuits. So let's talk honestly about the strengths and limitations here, because this is where we need to be a little more humble. The strength of the DSM is in its reliability, right? Two clinicians can often agree on the diagnosis using the same criteria. But the limitation of the DSM is in its validity. Now, DSM categories often group together biologically heterogeneous patients. That's why two people with the same diagnosis can respond completely differently to the same medication. The strength of the RDoC is the conceptual precision. It aligns better with neuroscience and pharmacology and translational research. But the limitation is its practicality, because you can't bill for positive valence system dysregulation. And you can't prescribe based on clean biomarker maps, because we don't have that yet. So we live in the tension, and that tension is the reality of modern psychiatry. So here's how I want you to adopt this for the purpose of this course and hopefully into your practice. You use the DSM to speak the language of the system, but you use the RDoC to think clearly about the patient. So if you only use DSM, you risk becoming a checklist psychiatry clinician, okay? And if you only use RDoC, you risk becoming completely untethered from real-world practices. So when you prescribe a medication, are you treating a diagnosis, or are you attempting to nudge a dysregulated system in a patient who's trying to function in this very imperfect world? So what is the primary limitation of the DSM-5 compared to the RDoC? Well, the answer here is B, right? So the primary limitation of the DSM-5 compared to RDoC is it does not account for shared neurobiological mechanisms across diagnostic categories. The DSM-5 is organized around symptom clusters and thresholds, and that improves your reliability and administrative utility, but it treats disorders as largely discrete entities. So in reality, many conditions like major depression, GAD, PTSD, ADHD, they all have these overlapping dysfunctions in circuits related to threat, reward, arousal, cognitive control. And the RDoC explicitly addresses this overlap by focusing on those dimensional neurobiological systems rather than a categorical diagnosis. The other options are incorrect because A is false, that the DSM-5 does have strong practical utility for billing documentation and guidelines. C is false because the DSM-5 is explicitly based on symptom thresholds. D is false because the DSM-5 actually underemphasizes biomarkers. Most diagnoses remain purely clinically descriptive. All right, so we have this 28-year-old woman, Sarah. She's reporting fatigue. There's difficulty concentrating, irritability. There's excessive worry about work deadlines and persistent sadness, and she's feeling worthless, and reports insomnia and a loss of interest in previously enjoyed activities. Now, before we begin labeling anything, let me ask the question I want you to carry throughout the course. What exactly are we looking at? Is this depression? Is this generalized anxiety disorder? Is this a comorbidity? Or is this a nervous system under sustained load expressing distress across multiple domains? Now here's the strong temptation. We want to reach for the DSM, and to be clear, we will use the DSM. It's what governs our diagnosis and billing and communication and research inclusion criteria and your board exams. So you're not above the DSM. Neither am I. However, the DSM asks very specific kinds of questions. It asks the question, does this patient meet enough criteria for long enough with enough impairment to cross a diagnostic threshold? And that's a categorical yes or no question. Yes, no, in, out. And if you apply that lens here, you might say she likely meets criteria for major depressive disorder, possibly with anxious distress, right? Or maybe she meets generalized anxiety disorder with depressive features, or both. And clinically, that could be enough. But now we have to complicate the situation. What does that diagnosis actually tell you about how her brain is functioning? Well, very little, because this is where the RDoC criteria enters. Not as a replacement, but as a thinking tool. And RDoC is going to ask different questions entirely, right? It's going to ask which functional systems are dysregulated and how. So instead of categories, it's looking at dimensions, right? We have negative valence system, sustained threat loss, cognitive systems, attention, executive function, arousal and regulatory systems, sleep and vigilance, positive valence systems, reward and motivation. And suddenly Sarah's symptoms stop competing with each other and start making sense together. Her worry and insomnia, sustained threat. Her fatigue and concentration problems, cognitive load and arousal dysregulation. Her anhedonia and worthlessness, loss and reward circuitry disruption. Now here's the critical teaching point, and I want you to hear this clearly. RDoC does not diagnose, it explains. DSM gives you that shared language. RDoC is giving you that map. And the maps matter, because psychopharmacologically, that does not cure categories. We modulate symptoms and systems. So this is where we have to be careful. We're not fixing Sarah. We're not correcting a chemical imbalance. We're making a strategic trade-off. If we increase her serotonergic tone, what improves and what might worsen? If we reduce arousal, what clarity do we gain? And what energy might we blunt? If we target sleep first, what downstream effects will follow? But here's the uncomfortable and necessary realization. It's very easy to fool ourselves here. These correlations feel like explanations, and the symptom improvement feels like causation. So now we're going to be seduced into overconfidence. And this is that intellectually dangerous territory I was telling you about, which is why the course began here. Before medications, before disorders, before algorithms. The goal is not certainty. The goal is disciplined reasoning and humility. How do you know what you know? And the ability to come alongside the patient. Not like a sage on the stage with an answer, but as a clinician who understands the limits of the tools. So sit with this tension, and we'll come back to Sarah again. And when we do, the question is not going to be, what do I prescribe? It's going to be, what system am I trying to influence at what cost? All right, what you're looking at here is not a diagnostic system. It's not a checklist. It's not something you're going to code. This is a map of human functioning. And the RDoC starts with a radical but clinically obvious premise. Psychiatric symptoms cluster around functional systems, not diagnoses. So let's take a look at the first one here, this negative valence system. This domain answers one question. How does the brain respond to threat, loss, aversive experience? It can either show you fear, anxiety, sustained threat, frustration. Now notice something important. A hyperactive amygdala doesn't care whether the DSM label is GAD, PTSD, panic disorder. It doesn't care if it's depression with anxious distress. The circuit is doing what the circuit does. So when a patient presents with chronic worry, hypervigilance, or dread, the question is not just which disorder, but which threat system is persistently online. If you dampen this system pharmacologically, you may reduce anxiety, but you may also reduce learning and vigilance and responsiveness. So every intervention is a trade-off. Now take a look at the positive valence systems. Now we shift to threat and reward. And this domain asks the question, how does the brain anticipate, experience, and learn from reward? So this is the domain of motivation, pleasure, reinforcement, habit formation. This is where anhedonia lives. And this is where addiction lives. And this is where nothing feels worth it anymore belongs. And notice the contradiction students often struggle with here. The same reward system can be underactive in depression and over-conditioned in addiction. Low dopamine signaling is not the same thing as healthy restraint. So when we say a medication helps motivation, what we are really saying is it nudges a reward learning system that is misfiring. No cures, no fixes, nudges. Now take a look here at the cognitive systems. This domain asks, can the brain hold, manipulate, direct information effectively? We're talking about things like working memory, attention, executive control, decision making. And here's where the misdiagnosis happens all the time. Is the patient distracted because they're inattentive by neurodevelopment? Are they cognitively overloaded by anxiety? Are they slowed by depression? Are they sleep deprived? You see, the DSM often collapses all of these into one label. RDoC forces you to pause and ask which cognitive function is failing and why. And that's why stimulants, antidepressants, anxiolytics, and sleep interventions can all appear to help attention, all while acting on completely different systems. Another thing to note is this concept of social processes. This domain answers, how does the brain process other people? Specifically things related to attachment, social cues, facial expressions, reciprocity. Social withdrawal here can mean fear, anhedonia, cognitive overload, impaired social cognition. Same behavior, different systems, different treatments. So if you don't distinguish this, you treat the symptoms but not the mechanisms. The next domain is this arousal and regulatory systems. Now this is the domain most clinicians underestimate. This is the system that governs things like sleep-wake cycles and circadian rhythms and stress hormones and baseline arousal. And the uncomfortable truth is, if this system is dysregulated, everything else will look broken. Attention fail, mood collapses, anxiety escalates, impulse control deteriorates, which is why sometimes the most psychiatric intervention is restoring sleep and not adding another psychotropic medication. Again, all about trade-offs, no cures. The final domain is the sensory motor system. Now, this domain reminds us that the brain is not separate from movement. So motor control, sensory integration, and feedback loops, this matters in things like Parkinson's, yeah, but also in things like agitation, psychomotor retardation, akathisia, side effects. We too often will label them as non-compliance. So the through line through all of this is take a step back and notice what the RDoC does not do. It does not tell you what to prescribe, what to diagnose. It doesn't tell you how to bill. What it does is it protects you from your intellectual shortcuts you could be tempted to take under pressure. This reminds you that the DSM categories are practical tools, whereas psychopharmacology is system modulation. And if you have clinical confidence without that mechanistic humility, you're in the danger zone. And this is the realization I want you to leave with. It's very easy to fool yourself with symptom correlations, which is why we start the course here. Because once you see patients as interacting systems, you stop asking what's the right drug and start asking which system am I touching and what might I disrupt in the process. So why do many patients meet criteria for multiple diagnoses? And why does it feel that both are clinically true, but it remains intellectually unsatisfying? So here you see the RDoC and the DSM-5 framework side by side. Well, take a look first at this DSM. This starts with what clinicians can reliably observe. So you see here clusters of symptoms, patterns that repeat, thresholds that allow you for agreement. And that's not a flaw, it's a design choice. The RDoC starts somewhere entirely differently, because it's asking the question, what underlying systems generate these symptoms in the first place? One is very pragmatic, one is mechanistic. And here's the key move that you need to pay attention to. So these frameworks are not competitors, but they're answering different questions. The diagnostic approach in the DSM is categorical. You either cross the threshold or you don't, right? That's necessary for communication, documentation, reimbursement, research standardization. Whereas RDoC, this is dimensional. Now, symptoms exist on spectrums, right? So varying degrees of arousal, cognition, reward, threat response. So when a patient has anxiety and depression, the DSM sees that as comorbidity, whereas the RDoC sees it as a shared circuitry. Neither is wrong, but each becomes dangerous when used alone. So take a look now at symptom categorization. So here's where the overlap becomes somewhat unavoidable. In the DSM, sadness belongs to depression, worry belongs to anxiety, inattention belongs to ADHD. But the patients, they don't read the manual. And fatigue, poor concentration, sleep disruption, irritability, these come up everywhere. Whereas RDoC forces a different question. Which functional system is failing and how? And that question protects you from that reflexive prescribing. Overlap of disorders, this throws quite the confession of the DSM. So this row tells that high comorbidity is not accidental. It reflects the fact that the brain does not respect diagnostic borders. RDoC doesn't eliminate that overlap, it just explains it. It will say that impaired reward processing can present as depression, anxiety, substance use, burnout. Same system, different clinical stories. Now let's be very clear and very honest. In real practice, you're going to diagnose using the DSM. You're going to prescribe within DSM-based indications. You're going to document using DSM language. But you should think using RDoC. You want to diagnose categorically. You want to reason dimensionally. And that's the integration that has to go on in your brain. If you skip the DSM, you're seen as impractical. If you skip the RDoC, well, you're seen as intellectually lazy. So the thing to take away here is the DSM tells you what to call it. The RDoC is to help you understand what you're touching. And once you understand what you're touching, you tend to become more careful, more humble, and you tend to pause and ask, if I modulate this system, what else might I alter? That question doesn't make you weaker as a clinician, it makes you safer. So this is dangerous territory because it's very easy to mistake correlation for causation and confuse symptom reduction with understanding or overestimating how much you actually know, which is why we begin here. This is not meant to demoralize you, it's just meant to train you to think clearly and cautiously and to be more responsible when you begin your clinical work. So let's start with the DSM because this is where the practice begins, right? Sarah reports to you sadness, fatigue, loss of interest, impaired sleep, difficulty concentrating. On duration and severity alone, she's meeting the criteria for major depressive disorder. At the same time, she's describing things related to excessive worry, irritability, persistent tension around work demands, and all of that aligns with generalized anxiety disorder. So what does the DSM do? It does exactly what it's designed to do. It assigns two diagnoses, major depressive disorder and generalized anxiety disorder, based on symptom thresholds and time course alone. And the DSM has done its job. But notice what just happened. We have named the suffering, but we haven't explained anything. So the RDoC now shifts the lens. So RDoC will ask different questions. What systems here are dysregulated, regardless of what we call the disorder? So here, Sarah's symptoms cluster around some shared mechanisms. Her sadness, worry, and threat sensitivity suggest hyperactivity in the negative valence system. Her sleep disturbance and fatigue point you towards a dysregulated arousal and regulatory system. Her concentration difficulties implicate cognitive control systems. Now notice something important. We didn't add diagnoses. We collapsed the complexity into systems, not to simplify it, but to understand it. So now we're going to treat these implications. Now here's where this matters clinically. The DSM-based treatment asks, which disorder am I treating? Well, as the RDoC informed reasoning asks, which system am I trying to modulate and at what cost? Now those are very different questions. A medication might improve mood but worsen sleep. Another might reduce arousal but blunt motivation. This is where that idea of trade-offs becomes unavoidable. We're not curing anything. We're just mitigating symptoms and increasing functional capacity and building resilience over time. And every intervention shifts multiple systems. So whether we intend to or not, that's the reality. So if there's one realization you need to leave with, it's that it is remarkably easy to fool ourselves with correlations as we see improvements and assume understanding. We see symptom reduction and assume precision, but psychopharmacologically, the mechanisms are inferred, not proven. And our confidence often outpaces the evidence. So that doesn't mean you stop treating people, it means you need to remember to tread carefully. So you'll diagnose using the DSM, but you're going to reason using the RDoC. And if you do this well, you're not going to present as a, expert sage on the stage. You're going to come alongside that patient as someone who understands the uncertainty and limits and act responsibly. All right, now I'm going to start summarizing some key things from this very long lecture. First thing you need to take home from this is these words that often get used interchangeably in casual conversation. They are not interchangeable in clinical reasoning. So reliability does what? It asks the very narrow question, if I measure this again, do I get the same result? And if a patient completes that PHQ-9 today and again next week and nothing has changed clinically, that score should be roughly the same. That's reliability. That's consistency, repeatability, all synonyms for reliability. Stability across time or raters. Remember, a tool can be highly reliable and still be deeply misleading. Now, validity asks a much harder question. Am I measuring the thing I think I'm measuring? A depression scale should identify depression, not anxiety, not trauma, not burnout, not sleep deprivation. But here's the problem. Many symptoms, as you now know, overlap across disorders. So fatigue and concentration difficulty and sleep disruption all can overlap. So this tool can reliably detect distress without validity, without validly identifying the source. And so that's where your clinical judgment will come in. The key difference is reliable tools are not always valid, but valid tools must be reliable. And reliability is a prerequisite. Validity is the goal. And neither one replaces your clinical reasoning. And now I want to drive home this very important concept. Now you already know this because we've said it a couple of times. What matters is whether you practice it under pressure. So correlation means these two things move together. Think about something like shark attacks and ice cream sales, right? So you would not say that ice cream sales are driving shark attacks. They're just both going up at the same time. So that's all. These two things move together. When one goes up, the other tends to go up. And when one goes down, the other tends to go down. That's it. No direction, no mechanism, no proof. In psychiatry, correlations are everywhere. Insomnia, depression, anxiety, GI symptoms, trauma history, substance use. They travel together. That does not tell us why. Whereas causation asks a much harder question. Does A directly produce B? To claim causation, you need evidence of a temporal order, a plausible mechanism, exclusion of alternatives. So that's why causation will usually come from controlled trials, longitudinal designs, intervention effects. And as you look at the psychiatric research, you'll know why that data cannot make causal claims. Now the key pitfall, the trap, is that the symptom improved after I treated this X thing, therefore X caused it. Wrong. Maybe. Or maybe not. Maybe you just treated the downstream effect. And then the condition naturally improved. Or maybe there's a strong placebo response. Or maybe multiple systems shifted at once. Improvement is not proof of causation. It's just a hypothesis generator. So if we confuse correlation with causation, you're going to over-attribute mechanisms and you're going to oversell explanations to patients, which will erode that very important therapeutic alliance. So we cannot become dogmatic about our treatments. So SSRIs improve anxiety and depression. That does not prove serotonin deficiency caused either, or that serotonin is the primary pathology. It just proves the system is modifiable, not that you even fully understand it. So strong clinicians say things like, these symptoms are associated with, this treatment tends to help people with this pattern. We do not fully know the mechanism, but here's what we're targeting. Lazy, weak clinicians that fail to think critically say things like, this causes that, or we know the reason, or the brain chemical explanation is. That certainty feels oh so comforting. but accuracy is far more ethical, and we owe that to the patients. All right, so now let's review further. The DSM and the RDoC are what? They're not competing beliefs, they're just answering different questions. So the DSM asks, does the patient meet criteria for a diagnosis? It is symptom-based, categorical, threshold-driven. Its strength is in its clinical reliability. They have a shared language, it allows us to bill and communicate, and legal and institutional consistency can be carried through. So when I say major depressive disorder or GAD, every clinician knows what I mean, and that matters. But RDoC asks a different question. What symptoms are dysregulated in this person? Is it mechanism-based? Is it dimensional? Is it transdiagnostic? RDoC doesn't care whether the label is depression or anxiety. It cares about negative valence, reward processing, cognition, arousal regulation. That's why the same patient can look like MDD on paper and GAD on screening and yet have one dominant neurobiological pattern driving both problems. So the key insight here is that the line the student usually misses is the DSM tells you what to call it. The RDoC is supposed to help you understand what's going on. DSM, classification. RDoC, conceptualization. So you can use them complementary, not interchangeable. So a good clinician diagnoses using the DSM but thinks using the RDoC, and you're going after treatment patterns and treating patterns of observation, not just the label. That's how you explain things like comorbidity without multiplying the diagnosis list endlessly. And that's how you stay more precise without becoming overly reductionistic. So psychopharmacology, as we've said, does not treat disorders. What it does is it targets biological processes, specifically neurotransmitter systems and the circuits that they modulate. So we have dopamine in reward and salience, serotonin in mood, anxiety, impulse modulation, norepinephrine in arousal, vigilance, and stress response. That's the level we're working at. Now notice what that implies. When you prescribe an SSRI, we're not treating depression as a whole or attempting to influence affective tone, emotional reactivity, threat sensitivity, cognitive flexibility. Those are the components, not the entire lived experience of the condition. So this is why the language matters. Medications don't cure conditions, they just shift the probabilities. They change the operating range of the system so that the patient has more capacity. Capacity to do what? To sleep, to think, to engage, to tolerate distress. That's the mitigation, not eradication. And that's not the failure of the pharmacology, that's the reality and limitations of biology. So the tension you sit with is if the symptoms improve, it does not automatically mean we understood the cause. And if the symptoms persist, it does not automatically mean that the medication was wrong. This is just probabilistic medicine, not mechanical repair. And that brings me to this key takeaway here. Holistic care doesn't mean anti-biological. And biological treatment does not mean it's the all-sufficient thing. Effective care requires biological modulation and psychological meaning-making, social context, developmental timing. Medication is only one lever, often powerful, but not the whole system. So as we move through the course, the posture I want you to adopt is to be confident enough to prescribe, but be humble enough to question your own explanations. And always remember, if you're not careful, it's very easy to make a correlation for causation error. And symptom relief for mechanism and neurotransmitters are for narratives. Well, thanks for holding on with me, and here we go. Let's tie this all up. Let me summarize this for you. So the take-home message from all of this is what? There's no pill for predisposing factors. I don't have a way to medicate the genetics, the temperament, the early attachment patterns, the developmental trauma, your personality structure, all of which shape the terrain before the symptoms even appeared or you walked in the door. There's no pill for that. Medication may reduce downstream expression, but it does not rewrite your origin story. There's also no pill for the precipitating factors that made you make the appointment, right? I cannot prescribe away the divorce, the job loss, a previous illness, a death, or any precipitating acute stressor. But what medication can do is buffer the nervous system so that the patient has enough stability to respond rather than collapse. That's the containment, not the cure. There is sometimes a pill for a perpetuating factor, but only when it's biological. So for example, chronic hyperarousal, impaired sleep-wake regulation, dysregulated reward processing, attentional control deficits. Biological, when the biology is actively maintaining the pathology or the maladaptive coping, medication can interrupt that loop of that perpetuating factor. But if what's perpetuating the disorder, the illness, is something like avoidance, maladaptive coping, substance use, relational chaos, meaninglessness, no dose adjustment or pill is going to fix that. And finally, I also don't have a pill for your protective factors. I cannot pharmacologically manifest for you or manufacture a sense of purpose. No pill is going to give you social supports or help you build skills or improve your values and morality or give you agency over a circumstance. Medications can create the conditions for those to develop, but it does not substitute for them. Medication treats biology only. Care treats people. So when you prescribe thoughtfully, it's not about silencing symptoms, it's about restoring capacity. Capacity for what? To engage, to learn, to change, to grow. So that's all for today. So if you ever find yourself escalating the dose to solve a problem in life or a behavioral problem or to solve a meaning problem, you're going in the wrong direction. There's no pill for those. So as we move forward, you'll hopefully have more clarity, but see you next time.